Good afternoon, everyone. Thank you for joining us today. I'm Heather Gatney, and I am the coordinator of the CVFS webinar series. Our host today is Yubaraj Acharya, Assistant Professor, Department of Health and Policy Administration at Penn State. Yubaraj is going to share his experience using the Institute for Social and Environmental Research, Nepal, to conduct population research that is not part of the Chitwan Valley Family Study. So this is going to be a little bit different because all of our previous webinars up to this point were focused on CVFS research. So we are just very thankful to have Yubaraj here today to share his unique experience using the research infrastructure in Nepal that the CVFS helped to create. We'll have a Q&A session after the presentation. We ask that you remain muted until then, unless you have a clarifying question. If you do need clarification mid-presentation, then please feel free to interrupt. Then during the Q&A at the end, you can ask any question that you have, and you can always submit a question at any time today using the chat feature. We'd also like to remind you that this webinar is being recorded. If you have any objections, you may disconnect at this point. A recording of this webinar and the slides will soon be available on the CVFS website. And with that, I will turn the meeting over to Yubaraj.
Great. Thank you, Heather. And let me unmute myself. Okay. Oh, I'm already unmuted. Thank you so much for having me today. So I was at Michigan for 5 years, as some of you know. So I'm grateful that I get to come back and sort of speak to everyone about my experience doing research in Chitwan Valley, although not part of the CVFS, like you mentioned. So my plan for today is to share experience conducting this particular study. It's titled Targeting Using Differential Incentives, Evidence from a Field Experiment. It's actually being published in the journal Economic Development and Cultural Change in January 2022. I'll share the timeline in a bit, but the study itself was, the experiment itself was conducted in 2015. So it's been a good 6 years. So the point of sharing the experience from that study is to sort of illustrate the kind of support that we often need when we do primary data collection or a randomized trial in Nepal. And so hopefully this will be useful, particularly to doctoral students who are planning to conduct research there. And towards the end, I will share some more practical suggestions on how to go about doing a study like this if you are so inclined. So I'll spend most of the time talking about the study itself. And again, as Heather mentioned, if you need any clarification, please just let me know along the way. I'm used to being interrupted. So here's the outline of the talk for the first part. And by the way, in terms of the time, I anticipate that I'll be done in 25 to 30 minutes. So we will have enough time to discuss at the end. Just to provide some background for this study, this is well known, that the uptake of preventive healthcare services tends to be very low, particularly in low and middle income countries. And on the demand side, the researchers have tried, providing subsidies, providing information, or combination of both. And then there are similar interventions on the supply side. What this study does is to focus on the differential access. So the fact that certain groups have different levels of access compared to other groups within the same country or community, right? And that is a major problem virtually in any country, right? Where disadvantaged groups tend to have lower access and worse outcomes in terms of health. And in many settings, going all the way from Sub-Saharan Africa to South Asia, outreach workers, like the ones that I study here in this study, they're often used as a way to improve access. And the expectation from policymakers is that they would reach to individuals who would otherwise not be reached. But the problem, though, is very often the disadvantaged groups tend to be underrepresented in these among the outreach workers. And there is now a critical threshold of literature in sociology suggesting that people tend to they find it easier to interact with people like themselves, with similar identities. It could be based on race, ethnicity, and gender in some cases. And that basically means that with the current outreach efforts, we may not be able to fully solve the problem of low utilization by disadvantaged groups. And so we need to figure out a way to reach to these groups who would not be otherwise reached with the existing efforts. Right? So that's what the study tries to do. In the research, in the study, I asked, can we incentivize outreach workers to refer individuals from disadvantaged groups through what I call differential incentives? So these are incentives that vary based on who the outreach workers refer for checkup in this case. And also on the demand side, I asked the question, if we provide financial incentives directly to the disadvantaged clients, are they more likely to show up for the checkup to utilize healthcare services once the healthcare worker sort of reaches to them? So those are the two main questions that we wanted to ask in this particular study. Just to provide a bit of context for those of you who are not already familiar, if you don't already know a bit about Nepal. Nepal has been the development agency sort of A+ student when it comes to under 5 mortality over the last several decades, right? The under 5 mortality has gone down from 118 per 1,000 to 39 in 2016 over the course of roughly 20 years. And the country met many of the Millennium Development Goals. However, there are these new challenges that the country is grappling with. And the study caters to two challenges in particular. One has to do with these continuing disparities in health access and outcomes across different groups. And previous studies have cited these disparities, not just in health, but broadly in all spheres of life, as the reason for triggering the conflict that was there from 1996 to 2006. And after the promulgation of the new constitution in 2015, there has been this renewed emphasis on addressing these disparities across groups. Now, in terms of the efforts, like in many other settings, researchers continue to document these disparities, but not much has been done in terms of actually addressing those disparities correctly. That's one issue. The other challenge, again, common to many low and middle income countries, is the shifting burden of diseases from the communicable conditions to these newer non-communicable conditions like diabetes that are rising rapidly. So these data are from 2016. The diabetes prevalence in Nepal is roughly 10% now, so quite high. And then with the ongoing changes in lifestyles and everything, there's no clear indication that it's going to subside without efforts. And it's not clear if the existing healthcare system is fully equipped to address this shift. And that there are studies that have suggested that the healthcare workers that we have now could be mobilized to address these newer challenges, but that has not been tested rigorously. So the subjects of this study are the female community health volunteers. For those of you who know the context in other countries, they're similar to the community health workers. In many settings, the female community health volunteers, whom I'll refer to as health volunteers from now on, they were created in 1989 as part of this large vitamin A supplementation program that was funded by USAID. There are roughly 48,000 of them in the country right now. They're all women with limited education. And in the previous administrative system, we had a change in the structure of governance around 16, 17. In the previous one, there was one health volunteer per ward. So ward is the lowest administrative unit in the country, and they've been cited for, they've been praised for, you know, the significant improvements that the country has made in child and maternal health over the years, and their primary role is in providing information, raising awareness, but increasingly they are engaged in these other tasks that they were initially not envisioned to perform. So the effectiveness of utilizing them, mobilizing them for these newer medical conditions that the country is saying is not clear. And just to clarify, this matters for the study design. They're all volunteers, so they don't receive any salary from the government. There have been talks of providing a salary, but right now they only receive some other benefits in terms of, you know, subsidized loans and what have you. So the third background that I need to provide, it relates to the ethnic groups in the country. So for its size, Nepal is known to be very diverse in terms of the ethnic composition. There are more than 106 ethnic groups in the country, based on the 2011 census. And for policy issues, very often the government categorized them into 6 broad categories. And in this study, I focus on, I use this even wider definition of advantaged versus disadvantaged. And so here, Brahmins and Kshatris and Newars would be in the advantaged groups. The remaining groups would be in the disadvantaged groups. So when I say disadvantaged versus advantaged, that's the distinction that I'm following. You have to keep in mind that there are differences within these groups, within advantaged and within disadvantaged groups. But then there are also differences within, you know, specific disadvantaged groups. So even within Dalits, there's substantial heterogeneity in healthcare utilization and outcomes. From a targeting point of view, probably makes sense to target at a higher level, which is why I follow this advantage versus disadvantage dichotomy. And other studies have done the same thing. But you know, the study comes with that particular caveat because there's that heterogeneity within groups. In terms of the representation of different groups among the outreach workers, in this table here, I have the proportion of the overall population, the proportion of health volunteers, and I also have data on diabetes here. So in the population, 54%, roughly 55% individuals are disadvantaged, 45 are advantaged. But if you look at the health volunteers, you know, 62% are advantaged and disadvantaged are roughly 38%. So clearly the advantaged groups are overrepresented. This is true in the study site as well as in the rest of the country. The diabetes prevalence, the numbers that I have here, these are, this was a little bit surprising because my expectation going into the study was that advantaged groups, because they have better access to processed food and what have you, they would be more likely to be diabetic, but that's not what we see here. I just wanted to point that out. So here's the here are all the things that we did as a part of this study. The key things to keep in mind are the health volunteers were invited for a training on diabetes, and then they were given referral cards that they could take to their communities and give to individuals in their communities. The individuals in the communities would take those referral cards and come to the clinic for a free checkup. So that's sort of the main setup, right? And then we vary, you know, what health volunteer gets for when an individual comes to the checkup, and what the individuals get if they show up. But broadly, that's the setup. And obviously, like any other study, we went through a series of steps in actually doing that. You know, taking approval from the University of Michigan IRB, the Nepal Health Research Council, and also the district health office at that time. Now, the most recent information that I have is that right now, if you want to do a study in Nepal, you also have to take approval from these municipalities, which are below the provinces. So there's that extra layer of approval that you need to take. And then we went to the health volunteers, the health centers, and these are called health posts. And then we collected information on the health volunteers pertaining to that particular health post. So every village, basically village development committee, has a health center, and that village development committee would have 9 wards, and in each ward there would be a health volunteer, right? So we went there, collected information on health volunteers, the basic information like education, experience, and the ethnicity, again, advantaged, disadvantaged, and then we randomized the health volunteers into arms based, stratified by ethnicity, age, and education. And we again visited the health posts to confirm the date of the training for the health volunteers, and then when the checkup would be held for people. We trained the health volunteers. We conducted a baseline survey, and then we visited the health volunteers at their home individually to explain the incentives. And I'll talk about the incentives in the next slide. And then we provided the referral cards and the letters that they would actually give to the clients. And I'll also talk about the letters in a bit. And then we held the checkups in all clinics at a time that we agreed with the health centers beforehand. And at that time, we also interviewed the people who showed up to the checkup. And at the end, we provided the incentives as promised to the health volunteers. I should note that at the end, all health volunteers received the maximum that was possible for ethical reasons. But while we were doing the experiment, they didn't know that was going to happen. So here's the key to the design. Right? So the randomization was at 2 levels. First, we randomized the health volunteers to 4 arms. And in the table here, you can see those 4 arms and what they received per referral. So just to walk you through this, in arm 1, right, in the low arm, irrespective of the ethnicity of the individual the health volunteer referred, the health volunteer received 20 rupees per referral, right? And in arm 4, irrespective of who they referred, they would get 50 rupees per referral. And at that time, 20 rupees translated roughly 20 cents. So you can think of these as cents if you want to think in dollar terms. The key innovation was in arm 2, where we offered a higher amount if they referred somebody from a disadvantaged group. So if I'm a health volunteer, if I refer somebody from a disadvantaged group, I get 50 rupees per referral. But if I refer somebody from an advantaged group, I get only 20 rupees per referral. And then in arm 3, which is not policy relevant, you would, in practice, you would never get more for referring somebody from advantaged groups. But we wanted to keep it there for comparison. So that's at the health volunteer level. And when the health volunteers visited the clients, the people in the communities, they also gave a letter that specified the amount that the individual would receive if they came to the checkup. So this was to see, how responsive individuals are to these subsidies on the demand side. So there's that second level of randomization, and that was also randomized. So every health volunteer was given, a stack of letters, and from the envelope, the health volunteers would not know what amount was mentioned inside the letter, inside the envelope. But it had a code, and so based on that code, we would be able to tell how much the clients would have received if the client came to the checkup. So the referral card that the health volunteers used looked like a boarding pass. They would write the ID number on top was stamped. So if we put the stub and the other part together, we would know exactly, we would be able to match the client to the health volunteer. Again, so the right inside of this referral card. The health volunteers would give to the client, and the left side she would give. And in both cases, in the stub, she would write the envelope number of the client. So based on that, we would be able to tell how much the client would have received if the client came to the checkup. So that's the yeah. And okay, so before I move on, actually, I want to pause for one minute and make sure that we understand the setup before I go into the findings. Does anyone have any clarifying question? Great. So I'll continue with the findings. So we had 72 volunteers from 8 village development committees. 69 of them came to the training, and they gave referral cards to 2,825 clients, and we were able to obtain complete information from 2,755 of them. So that's sample 1. So these are the people that the health volunteers received. The health volunteers reached out to initially to give the referral card. Of those, roughly 80% came to the checkup. Actually, it's more than that. It's roughly 85% came to the checkup. And we're able to interview the vast majority of them, close to 97% of them. And we had complete information on 2,336 individuals. So that's the sample 2, which is the sample of individuals who actually came to the checkup. These are the general characteristics of the clients. 60% were women. The average age was 52. The average years of schooling was 4 years. It's not surprising for this setting, particularly for this age group. And 56% of the individuals who came were from the advantaged groups. And as you can see, the primary occupation is agriculture for roughly 82% people. And among the health volunteers, the average age was 46. Somebody trying to. On average, they had 19 years of experience. So it looks like there were several of them who actually started working back in '89. And only 28% had education higher than grade 10, which is equivalent to the sophomore year of high school here in the US. So those are the health volunteer characteristics. The randomization seemed to have divided the health volunteers into similar arms, right? In the 4 arms, they were very similar, except age and experience, which was surprising because the information we collected from the health volunteer health posts beforehand did not match with the self-reported numbers from the health volunteers, which is why you see this decrease, because this is based on what the health volunteers said. But if based on the information that we received beforehand, they were balanced, more balanced. And also on the demand side, in order to look at the effect of that incentive on whether they show up, we need to make sure that this incentive amount is exogenous. And there we see that the incentives, the envelopes with different incentives amounts were evenly distributed across different age groups, gender, and so on and so forth. So the empirical approach for randomized controlled trials, it's straightforward, depending on the complexity of the design. And in here, it's straightforward design. So we look at for the main research question, we look at the number of referrals the number of disadvantaged referrals as a function of these incentive arms to the health volunteers. We also look at the proportion of disadvantaged referrals, so whether the person referred by someone is disadvantaged as the outcome. And then on the client side, we look at your chances of coming to the health center as a function of your disadvantaged status, the amount of incentive that you received, as mentioned in the envelope, and then we interact the two so we can see if the effect of the incentive was different for disadvantaged groups, the group that we are targeting. I'll walk through 4 main findings. And okay, we are doing okay on time, it looks like. So the first finding is that the disadvantaged referrals increased with differential incentives. The number that you want to look at here is the one in bold, and in the third column. And so going from the first model to the third model, it's just a different set of controls that we put in. The first one does not have any controls except the stratification variables. The second one has more, including the characteristics of the health volunteers. And the third model, we also account for the proportion of advantaged or disadvantaged clients within a ward. So these are the most precise. So we find that that these incentives that were geared toward disadvantaged referral increased the proportion of disadvantaged referrals by 11.6 percentage points. This was a big effect, and because we only have 69 health volunteers, although the number of clients is over 2,800. We also report these p-values from a randomized inference test. We didn't have enough power to be conclusive about the number of referrals. As you can see that the standard errors on column 4, the standard errors are quite big. So even though 3.6 referrals, an additional 3.6 referrals in response to that particular incentive is quite high, we couldn't establish that this was statistically significant. So the disadvantaged referrals increased with differential incentive, and that seemed to be true even when we looked at the clients who showed up. So the second sample that I mentioned, again, similar effects, and again, difficult to establish significance in the number of disadvantaged referrals. The second finding I want to mention is that the higher incentives seem to increase effort at identifying sicker patients. So we have data on whether a client who showed up to the clinic was diabetic, based on the sugar level test that was done in the clinic, and we find that across the 3 arms, right, relative to the low arm, in all 3 arms, there was significant higher probability of the client being diabetic than the control arm, the low arm. Right? So it looks like with higher incentives, health volunteers seem to be exerting more effort in identifying who's more likely to be diabetic. And part of the training was enabling them to do exactly that. The one concern with a study like this is if health volunteers might recruit fewer people if they are targeting overall income, or they might just increase the total number of referrals and not put in effort, right, to benefit from the incentives. But we don't find any evidence of that here. So what they seem to be doing is changing the mix of clients that they would refer otherwise, and getting more to the disadvantaged clients. On the demand side, the incentives had no effect. And in the paper, we provide a few conjectures on why this might be happening. The disadvantaged clients were 5 percentage points less likely to come to the checkup once they receive the referral card than the advantaged clients. However, the incentives didn't seem to affect either of those types of clients. In this setting, it appears that even a small amount was probably large enough to get everybody to come. And you can see that based on the proportion of clients who actually showed up, right? 85%, it's quite high. In any case, we found no effect of the incentives to the clients there, at least within the range that we are offering. Just as a further elaboration, those of you with economics background, I'm sure you'd like to talk about elasticity. So I put the slide there. So the incentive elasticity in this case is about 0.2. So we look at the change in the disadvantage referrals over the change in the incentive. And we didn't find any evidence of gaming by the health volunteers. So they were not opening up the envelopes and giving the ones that mentioned higher amounts to the friends and families, right? And also, but there were significant threats to external validity in this study. One, this was conducted right after the earthquake of 2015, which means people were likely working together on things, but then at the same time there was this ethnic tension going on in the western part of the country. So on net, which way the effects are biased, it's unclear. Also, many people have pointed out in previous presentations that this is such a unique setting. We've got these health volunteers that have been really effective. Can you really apply these findings to any other setting? So the study comes with these caveats. I put this slide here. I'm going to take a step back and talk more generally about the timeline of this study. I actually started thinking about doing primary data collection in 2014. For those of you who are in the doctoral program, this was the second year, at the end of second year of my PhD. And I received this award from the Department of Health Policy and Administration for an RCT that I had in mind at that point. And this involved providing micronutrient powder to children and offering that at different prices to look at the effect of subsidies on uptake. So I spent the summer of 2014 in Chitwan with Dr. Kimberly and others for another study that we had funding for. This was a pilot study collecting data on nutrition and diet among children under the age of 5. And the paper from that has been published. And my hope was to set up this RCT for which I had funding too. But after I went there, I learned that that RCT was not going to materialize. Basically, the problem was that the government was going to give the micronutrient powder for free through UNICEF. And so I couldn't charge people and see at what prices they bought it when the government was going to provide it for free in a couple of weeks, months later. So I had to drop that idea. Unfortunately, we had obtained the IRB approval from Michigan and Nepal Health Research Council. So it was quite upsetting. After I came back, I designed the current RCT, the one that I just presented. I defended the dissertation prospectus, and then asked for asked if I could use the money from that award to conduct this study instead. And because the original study was also meant to be a dissertation chapter, they allowed me to do that. I obtained IRB approval both at Michigan and the Nepal Health Research Council in the spring of 2015, but then the earthquake struck in April 2015. So things were on hold, and I wasn't sure if I was going to go ahead with the RCT. Thankfully, things started, at least in Chitwan, where ISER-N is. Things weren't that bad, and so I was told that I could go and do the study, and I was able to pull that study through in August and September of 2015. So the paper that I just presented, it was accepted last year, earlier this year, and it's coming out in print in January of 2022. So it's been 6 years since I did that experiment, but the paper is finally out, or will be out soon. Looking back, a few things that I would have done differently. One, and this relates to generally any study that we do on global health. I would have spent more time in the field before designing that first RCT and doing all the IRBs and everything, and just throwing things away at the end because it couldn't materialize. And around 2012, from 2012, there has been this shift in the field of development economics towards making sure that the trials are registered, and the researchers prepare this pre-analysis plan and submit them. I didn't do either of those, and that was a problem when I tried to publish the study. Also, I guess because this was one of the first studies that I did, in the consent form, I didn't stipulate that the data could be used for other studies in the future. And the IRBs have now told me that I can't write other papers because I didn't mention that in the consent form, including possible replication of the data. And just general methodological issues, I have thought about the design and statistical power more carefully. And the practical thing, after I went there to do the study, I realized how much time the local collaborators had to put in. So if I knew that, I probably would have looked for more resources here before going there to cover more of their time. And so that's the sort of looking back, I guess, hindsight is 30-30 bit, 20-20 bit. So for those of you who are planning to conduct the research in Nepal, including through ISER, which for those of you who don't know is the research institute where that's been conducting the CVFS over the last several years. My one suggestion is, start early. Nepal Health Research Council takes longer to review proposals than IRBs here in the US, right? At least the university ones. The latest I've heard is that they meet once a month. So, and they usually ask for edits, and they have different requirements in terms of what you need to submit. Things like you need to have a photograph. Most recently, I've submitted my passport information. So there are additional requirements. So you want to start early. Generally, everything takes longer in the field. So there's this advantage to starting early. The other suggestion is if you plan to do a study in Nepal, irrespective of whether you do it through ISER or some other NGO or research firm, my suggestion is to be there, go there and spend some time before you think about a study. Because particularly if you're from the region, like myself, I was born and raised in Nepal, and I sort of took it for granted that I sort of assumed that I knew the context well. And then I went there and realized that there were so many things that I should do differently.
Raj, I couldn't stand it. That's such an important point. I turned my camera on, I unmuted myself to plead with anybody who's listening to you to take that advice incredibly seriously. I spent a lot of years in Chitwan, but it doesn't matter. It's what study you're planning and thinking that through in the context of being there. Oh, such an important point, Raj. Thank you so much for making that point. I will shut up now.
Sure. Thank you, Bill. That was useful. I mean, Michigan paid for several of my trips, and I was fortunate to have mentors like Dr. Gimbire and yourself and others, and that helped big time in making sure that I went there a few times before I did this study. The other suggestion that I'd like to offer is really be cognizant of local collaborators' time and costs. Everything in the field takes longer than in the US. So especially if you haven't done research in low-income countries before, it's really important. I'll just give you an example. We had to take approval from the district health officer. And we went there, me and my local collaborator, and then we went there and we were told that he would be there anytime. So we just waited and for the whole day, but that meeting did not materialize, right? If you're thinking about how much time, if you had asked me before going there how much time I should put in for the local collaborator, I would probably say, one meeting, so 1 hour. And so things just don't move that quickly. So be cognizant of that. In Nepal, with the new federal setup, now additional approvals are required, and Dr. Gimber will be able to speak to that more effectively. But basically, you need to get approval not just from the central government, the Nepal Health Research Council, but also from these municipalities, and there are many of them now. So if you want to do a bigger study, more approvals are required. And there are several unforeseen costs that people may not be aware of when you think about, simply because things tend to move slowly. Things like, in this example that I have here, we're planning this training from the health volunteers, and some health volunteers couldn't make it because they missed the bus. So instead of covering the expenses for the morning meal and the lunch, we basically had to extend that for the whole day. So things like that. When you look at I guess the budget that local collaborators send, it's often tempting to think, oh, how come these things cost so much? But these are real costs. And also I've noticed, this is not just based in Nepal, but also in other places where I have ongoing collaboration. If you're an outsider, as in somebody affiliated with the university in the US, going to do research, they usually set aside all the time for you. So in other words, they need to be available on a fairly short notice if you need them. So they can't switch between tasks too easily. That there's not much of that flexibility, which means if you are there, right, you need to account for all of their time while you are there, because you probably expect them to be available on a short notice for if you need help. Just wanted to mention that. Now, if you decided to do research with ISER, and I encourage everyone to do it. I've now worked with at least 3 research firms in Nepal, a bunch of them in other countries, and I can say that the most pleasant and most efficient work that I've done has been with ISER. And I've received, and that study I received help with IRB approval, all other local approvals, translation, pre-testing of survey instruments, and any of the things could happen before I even went there. Logistical arrangements, things like hiring research staff. I've done studies with other NGOs where I've actually asked for someone from ISER to help me with this because I know they could do a better job. Data collection, entry, preparing data dictionary and making sure that everything is in order once you receive it here. And also, if you're just starting and if you're like me, you probably have no clue what it's going to cost, right? And so they've been very helpful with preparing the budget so that I don't get lost. I think I spent slightly more time than I was planning, but I'm going to end here. If you have any questions, and if you decide to do any research in Nepal or with ISER, please feel free to get in touch. But I'll stop here and open up the floor for questions and comments.
Thank you, Yuvraj. Durga, I'm curious, while other people are framing their questions, Yuvraj gave us an example of a person who, during the PhD program, engaged with ISER-N. And I know many of those people have been PhD students here at the University of Michigan, which is obviously easier to come spend time in your office or invite you to lunch. Durga, are there some examples of people who are not at the University of Michigan who have worked with you either during the PhD program or as a junior scientist somewhere to launch a project with ISER-N? Muted. You're muted, Durga.
Yeah, there are several of them. We have more students from outside of Michigan than from Michigan doing research in Chitwan. There were some from University of Washington.
Would you be careful to protect their identity in the sense of, I don't mean to disclose anybody's personal information, but could you give us a kind of an example or two of how, I understand, and Yuvraj, you're a good example because it's not like you were my student or Dirga's student sitting in the same bay with us for Truth in Advertising. Yubraj was across campus in another unit, had to seek us out, all those things. So it's a little bit more like being in another place. But Dirga, could you give us like an example of how that went for somebody who, without naming the name, without giving too much personal detail, but how it works for somebody who's at another place or didn't work?
Yep, I mean, ISER-N has, this mechanism that students from other universities can apply. There is a proposal review form. ISER-N has a committee to review those proposals. And then if they are accepted, then they can work with ISER-N to run their projects in Nepal. And people have done several students. I would say at least a dozen students from different universities has conducted their, dissertation research in Nepal or in Chitwan. Half of them were on environmental science. Some of them were in social science, and Yuvraj one who is in economics, and there are other in health too. That's it.
Yubraj, I was curious about this too. You conducted a randomized controlled trial, and thank you for explaining some of the important details of that. And I always think of ISER-N as best known for this panel studies, and they've of course been doing this one with me for many years. They've also been doing one with a bunch of scientists there at Penn State with you for some years. You've done other random controlled trials for people too. Rebecca Thornton's example occurs to me. Yubraj, I don't know if you'd worked with Rebecca or engaged with Rebecca before you did yours, but I guess, Yubraj, how did you find the randomized controlled trial to be strange and different, or did everybody seem like, oh yeah, we know what that is, we know what you mean?
Yeah, thank you for that question. Yeah, I was aware of Dr. Thornton's work before I designed mine. And being at Michigan, and if you do development economics with a health focus, it's sort of the route that many people go. And I've actually thought about doing a randomized trial when I started my PhD. Just because around that time there was this big movement towards doing more field experiments, and that seemed to be the nicer thing to do for causal inference. But for my second chapter, I actually did a secondary data analysis of the census data. So it was more. I didn't think there was like a specific point when I decided that I would do a randomized control trial, but it all hinged on whether I would find funding, of course, and the department that I was at, they were really generous with that grant that covered all of the expenses. Some of it was subsidized by ISER-N, as Dr. Thimira knows, but
understood. I want to urge other people to take advantage of the few minutes we have left, but while you're composing yourself, to turn the camera on and ask Yubraj a question. Yubraj, here at Michigan, you must have had somebody advising you on random controlled trial design who was not Dr. Gamiri or me or anybody from ISER-N. Is that true?
Yes. So on my committee, I had Dr. Dean Young, who is an affiliate at ISR. And I mean, he's the guru of randomized trials. So
we work with him a lot.
Best in the field. So my primary advisor was Dr. Edward Norton. He had done some small trials in the US, but not in global health setting. So I would say two of them were instrumental in sort of helping me finalize the design and taking it through the publication process as well.
I don't have a question, but Yubraj, I just wanted to thank you for all of that practical advice at the end. I think it echoes a lot of my experience working with ISER-N, and it was just framed really nicely, particularly for doctoral students. So thanks for putting that all together in such a nice package.
Thank you. My pleasure.
Yeah, no, I agree. And Emily, you're in a position to make a point that you're also in a position to make that I am not, which is it's the comparison to your other experiences, you working with other collaborators in other settings, either other collaborators in Nepal or other institutions, in other countries, which I feel is so important in terms of delivering the message. Hey, these folks at ISER-N can really help you out in a way that's a little bit more seamless than you're used to because they so understand what it is you're trying to accomplish.
I agree. Yeah, and without disclosing any identity, of course, I've worked with several research firms / NGOs in Nepal, and I think in all cases I've either sent somebody I know really well to sort of look over the shoulder and make sure that they do it right. With ISER, and I think it's been one thing that you can be sure of is the quality. So having worked with them at least on 2 studies so far, I've seen how the people work on the ground, and I can vouch that they're not going to compromise on the protocol, so that's really assuring, because we want to do good research and make sure that all the ethical considerations are met and are rigorous. So that's been the so I try to gear students towards ISER now because I want to make sure that the research is done properly above everything else.
Well, no, thank you for doing your part of that, Yubraj, which is to publish the results in a journal like Economic Development and Cultural Change. That's a great accomplishment for any of us, economist or otherwise. And I think that's one of the messages to students about the importance of this quality control aspect is whether you're underpowered for certain tests or certain results don't turn out the way you want, that stuff is always going to happen. It's when the field team or people helping you with the design implementation somehow mess up something entirely that you're going to lose your chance to publish in such an outstanding journal, which I assume you will enjoy benefits of that for years to come, and that's what we want for our students or any other students working with ISER-N, and it's that kind of long-term gain you get from the quality control aspect that it's pretty easy to say, oh, well, what's the big deal, until several years later.
Right. I agree. Thank you.
Oh, thank you.
Yubraj, I'm curious about ISER-N's role in terms of interacting with the subjects. Did they interview them? Did they train them, the health volunteers?
So for the training, we had a endocrinologist, I think that's the word, a medical doctor who does diabetes, doing the training. But the logistical side of things, yes, ISER helped with the organization of it. And the training, we actually did it in all health facilities. So we actually traveled to all the health facilities and did the training there, with the overhead and slides and everything. But yes, so the ISER helped with the logistics. As far as interacting with the participants is concerned, ISER has several. I forgot the exact number, Dr. Gimere, but they tap into this group of enumerators that they've trained over the years. And so we had, in our study, we had 20 enumerators and 8 nurses at each of those checkup sites. And we needed that many because the checkup was done in the morning from 6 to 9 before the health centers opened up. So we had to do them quickly, and so we needed really many people. And then obviously we had to do it in privacy, which meant basically walking to a corner with the respondent before they come back for the checkup. So ISER helped with all that.
Any last questions? It's almost 3 o'clock.
Yeah, just one last question before we end the session. Okay, thank you very much, Yubraj. My name is Paul, one of his students at Penn State. And well, we learned a lot about your experience with this with your dissertation. But just to ask, I understand that primary data collection can be time consuming, and thank you for the experience that you shared. But how about the costs? Given that secondary data, especially from in the US here, can be pretty expensive. What's your opinion about the cost for primary data research and secondary data?
Yeah, thank you, Paul. That and also for making time today to come to the session. Yeah, cost it is probably one of the biggest barriers because of which doctoral students don't do primary data collection. In this case, I was able to pull through resources, pull the resources from the department. Some of it was, like I said, subsidized by ISER, and the International Institute at Michigan. So almost always you end up actually pulling resources from multiple sources, and unless you can write a big grant. But I would say, I mean, if you can do that, it's worth it, because this has been, this. I mean, I started with that trial. I have at least one under design and one that's ongoing right now. If I hadn't done that one, I probably wouldn't have done these. And so to answer innovative questions, very often we need these trials. And if you can get that training while as a doctoral student, when you can always bug people with questions, it's a great opportunity. So I would say, every doctoral student should aspire to do that, or do at least some data collection, even if it's not a trial. I guess the other thing that I didn't mention is, if you can, once you put in so much effort, if you can get more papers out of it, that should be the goal. I didn't think about it as a doctoral student. I just thought about this one big paper that I was going to write. But I've also seen that when people spend so much time doing primary data collection, people tend to at least get multiple papers, and you can put in local collaborators and do all that.
Okay, I think it's just about 3 o'clock. Thank you so much for presenting today, Yuvraj.
Thank you for having me.
Really
Appreciate it.
appreciate it.
Thank you so much, Yuvraj. Yeah.
Thanks everybody for joining us too. Thank you, Raj.
Bye-bye. Thanks again.